Hello, everyone. Excellencies,
مرحبا بكم
Frank
جميعا
Carter.
أصحاب
Good
السعادة
afternoon, and thank
الأصدقاء
you for taking the
الزملاء
time
أسعد
to join
الله
us,
مساءكم وشكرا على
especially as I
تخصيص
know it's
الوقت
lunch period.
للانضمام إلى
My name is
جلستنا
Sultana. I'm
هذه.
the
أنا
CEO at the
اسمي
World
سلطان
Innovation
وأنا
Summit for Health,
رئيس
which is
التنفيذي
global health and
لقمة
Qatar Foundation.
الصحة،
And I'm
ونحن
pleased
جزء
to say
من
I'll be moderating the session
مؤسسة
today.
قطر، ويسعدني أن أدير هذه الجلسة اليوم.
Vaccines are at the heart of how modern societies counter HIV disease.
اللقاحات هي
They
الطرق
are
التي
our
تواجه
most
فيها
potent tool against adaptability
المجتمعات
and will be critical to our
الجوائح،
future
وهي
resilience.
بالغة
Therefore, the
الأهمية لأي
faster and
استجابة
better vaccines
مستقبلية.
developed
لذلك
and
كلما
deployed,
زادت
the
سرعة
faster the
تطوير
incipient pandemic can be
اللقاحات
contained and controlled.
ونشرها، تزداد قدرتنا
But to
على
fulfill their
السيطرة
key function of
على
preventing diseases,
الجوائح.
vaccines must be developed,
اللقاحات يجب تطوير
they must be
اللقاحات
distributed,
ويجب
and they
توزيعها،
must be administered to the population.
ويجب توزيعها
COVID-19 showed us
وإعطائها
again global health system resilience
للسكان.
requires a
طبعا
multifaceted
هذا
approach,
الأمر يتطلب
incorporating
طرق
robust
متعددة
infrastructure, financing,
الجوانب، منها
skilled healthcare
التمويل
professionals, and
وتطوير
adaptable
قدرات
policies.
ومهارات العاملين في القطاع الصحي
COVID-19 vaccines
وسياسات
were
مصاحبة
remarkable in the
لها.
speed that they were manufactured,
طبعا لقد
tested, and
أدهشتنا
trialed.
السرعة التي تم
As a
من
result, the
خلالها
public may
تطوير
well expect
لقاحات
greater yield
كورونا
of vaccine.
19 من حيث السرعة وقدرتها على مواجهة الوباء.
Well, COVID-19 has shown that.
كورونا
It's shown us what we can do with
19
collective will
أردنا ما
and
يمكننا
ingenuity.
تحقيقه من خلال
For the
الإرادة
poorest countries, it has challenged
الجماعية.
the resilience of existing
للعديد
healthcare
من
systems
الدول
like never before.
تحدت منظومتهم الصحية
Resilient healthcare
بطريقة
systems can
غير
only be
مسبوقة،
achieved under
ويمكن
such
تحقيق
conditions
ذلك
by building
من
resilient
خلال
and
بناء
sustainable
القدرة
systems
على الصمود
that have the
والتعافي
capacity to deliver
ومنظومات
vaccines
قادرة على
quickly,
الاستدامة
how to
لبناء
foster
قدرتها
global
على
innovation
تطوير
and investment in
اللقاحات على قدم
technology in the
المساواة
poorest
والاستثمار
communities.
في
This
التكنولوجيات
discussion
في
will feature
المجتمعات
high-level representatives across a
الفقيرة.
number of
هذا
organizations
النقاش سوف يسلط
that will
الضوء
shed
على
light on the lessons learned and
مع
future plans for
ممثلين من
addressing
عدة
healthcare
مؤسسات
disputes and
ومنظمات
pandemics,
لكي يناقشوا الخطط التي
exploring
يمكن
how
من
vaccines are
خلالها
developed,
مواجهة
distributed, and
الأوبئة
work without
وتطوير
multilateral
اللقاحات.
investors in global health. Some nations should
بعض
also fight against
البلدان
diseases
قد
as
تخسر
a chance
معركتها
to
ضد
achieve
الأوبئة
equitable and
وقدرتها
sustainable
على
access to
تحقيق
life-saving health
القدرة
interventions.
على
To
التدخلات
unpack all of
الصحية
this,
التي
I'm
تنقذ
delighted to be
الأرواح.
joined by
يسعدني في هذه
Professor
الجلسة
Adrian
لمناقشة
Hall,
هذا الأمر.
the director of the Jenner Institute, and Lakshmi Mittal and family professor of vaccinology at the University of Oxford. Lady Rosalind Carter, chair of the board of the Global Fund, the organization tasked with coordinating global funding efforts to eradicate the three pandemics of HIV/AIDS, tuberculosis, and malaria. At this point, I would like to declare a proud interest that WISH is the first Friends of the Global Fund organization in this region. Professor Abdul Latif Al Khal, Deputy Chief Medical Officer for Hamad Medical Corporation here in Qatar and head of Qatar's Infectious Diseases Division. And finally, we're thrilled to be joined by His Excellency, the Honorable A.K. Abdul Momen, Minister of Foreign Affairs for Bangladesh, somebody with a huge amount of experience in operating within the global UN framework and with first-hand experience in Bangladesh's fight against COVID-19. So, distinguished members of the panel, we thank you for joining us. So I'm going straight to questions and Adrian. Professor Sir Adrian, how has the landscape of vaccine development evolved in the post-COVID-19 era? And what lessons can be applied to enhance the speed and efficacy of vaccine development for future health challenges?
Thank you. Well, clearly COVID-19 was a global disaster in many senses, but for those of us involved in vaccine R&D, it provided funding that we had never had before, global understanding of what vaccines can and cannot do, and a real focus on what we should be doing to protect ourselves and global populations against outbreak pathogens. So there was an upside. But of course, what we need to do is to learn from that experience. And I'm afraid there were many, many learning points. One is that we can develop vaccines much faster than we normally do. My day job is making a malaria vaccine. We've got there. It's taken 30 years. It could have been much faster because there are constraints and checks and balances in the system that weren't there during the rush to make an outbreak pathogen vaccine. And that was very successful, that rush. So we now are in a position where we have technologies, RNA vaccines, viral vector vaccines, traditional protein and adjuvant vaccines, and perhaps somewhat less so the inactivated viral vaccines, all of which provide a suite of technologies that we have used and can continue to use to respond pretty quickly. And as was clear to many people, nobody knew how long it would take to make a vaccine, simply because nobody had ever had the support and the financing and the regulatory activity and response speed that we had during the pandemic. And the answer was not 2 years or 3 years, it was under a year for 3 different vaccines. So again, that's good news. I wish we could do it in normal times. It would help global health, particularly. But stepping back, what are the 2 big challenges that I think we could address now that need to be addressed and are actually something of a risk for vaccine deployment during the next pandemic or major outbreak? One of those, in a sense, is education. There is a lot of vaccine hesitancy. There is a lot of lack of understanding of what vaccines can offer and do and should do in the future. And this really is a matter of public education and having open and frank debates with the anti-vaxxers, who are a small percentage of every population, but don't have strong arguments. So let's have those discussions and see where we go. And part of that educational process is the understanding of risk. Everyone thinks they understand a 1 in 10 risk. We go betting on horses and all sorts of things. But when it comes down to it, it was clear to me that most people didn't really see much difference between a 1 in 1,000 and a 1 in a million risk. There's a very big difference between those two. Vaccines are in the 1 in a million risk range, not the 1 in 1,000 or certainly 1 in 100 of a serious adverse event. So that's communication, that's explanation. The second problem is global supply of vaccines. We did supply billions of doses of vaccine over a year or so, but it was very inequitable in distribution. Africa did particularly badly. At one time, 75% of Americans were vaccinated, 4% of Africans. We can't allow that to happen again. And of course, every area somewhere in between those 2 extremes. So what was stopping that? Lack of coordinated planning, what we do with the next pandemic vaccine. But most particularly, and we still have this problem, we don't have enough places to manufacture vaccines. Simple as that. The world record for vaccines in a year of any type was a flu vaccine, 400 million doses. We needed 16 billion doses for 8 billion people of a COVID vaccine. That took much longer than it should, mainly because all the vaccine manufacturing plants were busy. They were full. They had to stop what they were doing. They had to be persuaded to do that. And most of them, except in East Asia, are not, and South Asia, are not enormous billion dose producers. So we need more manufacturing plants. We need them regionally. Yes, we have them in East Asia, particularly, in the Americas and Europe to some extent, but very little in this region and in Africa. We can do something about that, and I suggest we do it now.
Thank you. Thank you, Professor Hill. So turning to a more global perspective, Lady Roslin, as chair of the board of the Global Fund, you know only too well for vaccines to work, we need strong, sustainable healthcare systems in place. What mechanisms can be put in place to ensure equitable access to resources and technologies across nations during healthcare emergencies?
Thank you, Sultana, and good afternoon, everybody. At a global level, we need mechanisms where agencies work together, just like the Access to COVID Tools Accelerator, which was created during COVID, and all the major multilateral health organizations cooperated in a way that they probably hadn't before to try to ensure more equitable access to the COVID tools. But as Sir Adrian's pointed out, we really had a true track pandemic where people in developed countries had access to vaccine, and tests and treatment. But in the developed world, that was not the case. So regional manufacturing is clearly one answer as a mechanism. But we have to go back to what national efforts need to be made, and that lies absolutely in strengthening health systems in low and middle income countries. The Global Fund is the largest provider of grant funds for health of in the world. So not just for HIV, TB, and malaria, but also for health system strengthening. And about 1/3 of our money, about $1.5 billion every year, is spent on health system strengthening programs in 120 countries throughout the world. That's really the backbone of the ability to respond in the future to future pandemics. But we also argue that it's the infrastructure that you need today for fighting infectious disease, which is the base infrastructure you need for the next pandemic also. Countries that were more successful in their COVID response were countries that did have functioning supply chains, did have good laboratory systems, good diagnostics in place. Um, and we need to build those systems for the infectious diseases we face today, and that will be the base for the next pandemic.
Just a follow-on question. I understand that you had to reframe your operations because of COVID, and you did become a support system for COVID. So I think that there is a look at how the Global Fund operates and maybe looking at how you respond to pandemics using the infrastructure that you already have in place because of the work you're doing within strengthening of healthcare systems.
Right at the beginning of the pandemic, we realized that we had to respond to it as well. And one of the advantages of the Global Fund is that we actually are quite nimble and can change. And we had money in all the countries that had grants, which we immediately said, well, you can use that for COVID and then reprogram. We'll top up the money that's already been allocated for HIV, TB, malaria. And we had a relatively rapid system of countries submitting grant proposals for COVID, for their COVID response, and approval system. The initial money was already in country, so countries could spend money virtually from day one on COVID-related needs. So we actually have allocated $5 billion since 2020 on COVID response. We were the largest provider of grant funds for all the non-vaccine tools for COVID. So tests, treatment, oxygen, PPE for health workers, and so on. And as this year developed, and COVID wasn't the emergency that it had been, and part of last year as well, we still had some money that we hadn't spent, even though it had been allocated to countries, and countries themselves realized that they needed to change their priorities. So all of that unspent money has now been reprogrammed and pivoted to health system strengthening.
I was going to say saying you had extra money here would probably not be good, but I'm
Well,
glad you spent
we were
it.
very fortunate that that $5 billion was additional money,
Yeah, that's
and we
remarkable.
thank our donors for that. But we're still short of funds for the everyday HIV,
Thank you.
TB, malaria
It's
work.
good to underline that point always. Thank you. Moving on to Dr. Al Khal. So, Dr. Al Khal, as we are in Doha, it's really good to get a Qatar perspective on this topic. So, I'm going to begin by asking you, what are the key components that contribute to building resilience in healthcare systems with an eye on Doha?
I want to start by saying before COVID pandemic, we didn't really speak about resilience that much. This word rarely came up. We were talking about pandemic preparedness, epidemic preparedness, and doing exercises and drills, but not specifically about resilience. But with the COVID pandemic, the world attention now is steering towards resilience and building resilience in health systems, whether at national level or at healthcare system level, or even at clinics levels. Um, and there are multitudes of shocks that are ongoing. COVID is not over yet. We have to deal with the increasing respiratory viruses that are spreading in the winter during the cold months. There are global conflicts that are happening around the world, and there is the climate change that we have to deal with. Pandemics are inevitable, disasters are inevitable, and health systems have to deal with them. They will occur. It's just a matter of time. Emerging risks include more infectious disease pandemics, whether due to flu or a new coronavirus virus or other viruses. Um, in addition to more chronic stressors like aging population and growing incidence of chronic diseases. Developing resilience of health systems ensure that they are able to withstand acute and chronic shocks. And this is a window of opportunity because this is a period of relative stability. And this is the time when we really have to work hard so that we don't have to suffer during crisis. Building resilience helps countries circumvent future costs, so it may end up being money saving as we invest in existing health infrastructure and preventive programs. This automatically enhances our resilience and make us more prepared for more acute and chronic shocks. So there are several important components of resilience in a health system that I will mention the most important ones. First and most important is governance. Health system governance, which is the steering and the decision-making function of a health system, is essential for the health system delivery on national health policies, objectives, and that are needed during disasters. Having a robust governance with the quick and effective communication channels responding to shocks should be at the heart of our resilience and our preparations, as it connects all components of the national response and draws the necessary resources and political support. Second is intersectoral collaboration. We did, I think, really good job here in Qatar with the intersectoral collaboration, where typically the government and with leadership of the Ministry of Health would mobilize, coordinate, and will mobilize and coordinate the engagement of critical stakeholders. Um, Coordination and alignment of activities between governmental ministries and other agencies like private healthcare providers, NGOs, the private sector, international organizations, and communities. Third important component is financing. And, the financing was very important, procuring vaccines, for example, and more ventilators. So effective investment and financing and transparent procurement systems to minimize risk of corruption are key to building health system resilience. The efficient allocation of funds is particularly crucial when government budgets are limited. And while the scale of financing is important, the system's ability to be flexible about redirecting finances is also important. Fourth is information governance. One cannot emphasize the importance of investing in well-functioning electronic health information system that ensures the production, analysis, dissemination, and use of reliable and timely information on health determinants, health system performance, and health status. Such systems are very valuable during crisis as they generate real-time data that can be used for making decisions and policies. Fifth is health workforce. High quality human resource that's well staffed, well trained, and motivated is essential to maintaining health systems performance. Having adequate health workforce during stable times is key component to a resilience of a health system. Sixth is physical infrastructure. The distribution, location, and design of physical health facilities will play an increasingly important role in determining health systems' resilience, given the rising frequency of epidemics, climate change related natural disasters, and chronic stressors. Another important component is delivery. In times of crisis, health systems should be able to adopt alternative methods of delivering healthcare, for example, telemedicine, where it minimizes the interaction between patients and to the healthcare facilities, and actually is a more efficient way of providing care to the mass. Uh, Eighth is medical products, vaccines, and technologies. A well-functioning health system ensures availability and equitable access to essential medical products, vaccines, and technologies of assured quality, safety, and efficacy and cost effectiveness. Technologies can also include things like apps for smartphones that enhance the public health surveillance of disease and also to help people get more better access to care. There are other important elements of a resilient system, including things, for example, investing in preventive care, like was mentioned earlier, strengthening the national vaccination program, which can be used to leverage mass vaccination of the population in case of pandemics, universal access to care. In the absence of universal access to care, which is the basic necessity of the health of the population, then it's hard to talk about health system resilience. Good politics, there are, of course, good politics as there are bad politics. Good politics can be very helpful during crisis. They can engage the community, they can send the right messages, they can show solidarity and leadership. Effective communication and platforms and tools using mass media or social influencers to fight the misinformation that spreads very easily in the community. And last is stockpiles. It's very important really to build your strategic stockpiles of medicines, essential medicines, antibiotics, medical equipment, and other devices.
Thank you, Dr. Khan. We're moving on to Mr. Momin. Bangladesh has won international praise for its approach to vaccine deployment. From your perspective, how have international organizations contributed to vaccine development and deployment, and in what ways can their collaboration be optimized to address global health challenges more effectively?
Thank you very much, the moderator, honorable uh, panelists, excellencies, and audience. Assalamu alaikum, peace be upon you all. At the very outset, I would like to thank the government of Qatar for inviting us to this event, and especially to wish for organizing such an event. I think we should have more workshops and seminars on this topic because COVID really changed. It cost a lot. Both it is an unprecedented event, both in social and political terms. There was total disruption in the societies. It really, cost the whole world. 6.5 million people died of it. Of course, we are lucky. In Bangladesh, only 28,000 people died. No wonder we are the number one in managing the COVID in all of South Asia. And that's not happened by accident. It happened because of targeted approaches. Our population is 170 million, and that of US is double of us, which is that 330 million. In USA, 1.2 million died, almost 43 times more than us, in spite of the best medical facilities. We don't know, we don't have those. First, I would like to say how we achieved this success. One is we had the campaign, all across the country. and government work as a unit, as a teamwork. All ministries, all security forces, and including the volunteers and political parties, they got all involved and in the process. And the other thing is we have established capacity because of EPI vaccination. We have an established. You'll be surprised that one single day we vaccinated 120 million people. Yeah, 100 and can you believe it? It's enormous. Given vaccine to 120. It's because we have an existing capacity facilities. And there was serious cooperation. And that resulted. But the problem we faced was the supply chain. Initially, we were not getting enough vaccine. And therefore, it took us, we could save more life if we have got the vaccine on time. We are thankful to USA. Initially, they are not very reluctant to give vaccine to us because our fatality, total fatality was low. They were giving it only to those countries where fatality is high. Eventually, they started giving us. And once they gave us, we make best use of it. And therefore, we reduce our total fatality. Now, here, I'm thankful to international organizations like WHO, like CPI, Gavi, Vaccine Alliance, because they spearheaded a movement to provide vaccines. It is they who really helped us. And then, of course, under the COVID. And the USSC was very good. Once they started giving us the vaccine, they also provided us equipment so that we can take those vaccines and keep them refrigerated and take those vaccines to the rural areas. And it worked out very well for us. So in this case, I believe uh, that our observation is this vaccine should be given to all countries uniformly. Everyone has a right to have a vaccine because one group of people, if they remain infected, then no one is out of this danger. So this is a lesson for us. We have to look into the future that everyone should get the vaccine uniformly on time. We should build a system so that any disaster like this ever comes again, then the world should be ready to help them out. And we should build in the other is we must have continuous research so that we can develop better opportunities, better facilities. And we have been arguing vaccine should be a public good. In those cases, we should ignore these property rights. And if that we do, many countries might come up with, they have the, for example, Bangladesh has the capacity to produce vaccine. But because of that, the property right, intellectual right, cannot do it. So this should be made, this sort of products should be made public good so that other countries can produce and distribute, you see. So, and this, I believe, another area where is, has been logistic support. We need, we have to make ready all the logistic support across the country. And most important is power of collaboration, partnership. We would not win this war without a strong cooperation and partnership. We work together hand in hand with WA, with the Vaccine Alliance, with Gavi, with COVAX, and that is the key of success. So in future, this tells us that this world is one little small, village, and if anything comes up here, any serious issue comes up here, cooperation, collaboration, and continuous discussion and dialogue are essential to overcome those challenges. So I would say the lesson of these is that in future we should be ready to attack this sort of issues on a collaborative way. And we should develop institutions so that they continuously do research. If there is anything like that, they should produce the vaccines and immediately disseminate information across the nation. And that could help us to avoid such disasters. Thank you.
Thank you. I think your country is an exemplar in terms of collaboration within the country and collaboration with the main entities. In terms of looking at the resilience of healthcare systems and affordable care, um, Professor Hill, I just wanted to go back to the malaria vaccine because in terms of a game changer, I think that I would love to hear about what makes this malaria vaccine different to its predecessors.
Yeah, so briefly, three things. There is a malaria vaccine license from GSK already. The problem there is that the supply of that is about 6 million doses a year. You need 4 doses per child. There are 45 million children born in Africa every year, Africa alone, who would need a malaria vaccine. So it just isn't enough. So the big difference is, as with COVID, we partnered strongly with the Serum Institute of India in Pune, and they are they are, I think, the world's largest vaccine supplier, and they're able to make a couple of 100 million doses or more as necessary. But of course, one of the big advantages of going to scale is your cost per dose drops. So this will be sold at UNICEF have just announced $3.9 per dose, which is a very affordable price compared to many other new vaccines. And
Just jumping in there, what is the previous price for a malaria vaccine?
the GSK one is just over $10.
$10.
So, but the supply is the bigger issue, and our efficacy is around about 75%, which is an improvement as well. So those three factors are very exciting, not just for reducing this horrendous 640,000 deaths a year from malaria, but also in terms of moving towards malaria eradication, which should be achievable in the lifetime of the vast majority of people in this room. It's a doable solution.
Absolutely. Thank you so much. Lady Roslyn, in terms of the support that you provided for COVID, what do you perceive in future pandemics would be your response given what you were able to mobilize within the healthcare sector?
Not knowing what the next pandemic might be, it's a little bit hard to answer that. But I imagine we would do much the same as we did before, move quickly to respond. Agility was absolutely important, and speed.
Are there systems that are currently in place because of COVID that has reframed or
Well, we rely on national systems. We don't implement programs ourselves anyway.
Absolutely.
We fund what countries ask us to do, or say what they want to use our money for. Yes, you can guide the way that money's spent, but we don't implement it. It's all done to partners within each country for the implementation. But in terms of the policy direction and the provision of money, that's what we would be doing.
A really key factor it is.
Yeah.
Absolutely. Thank you. So I'm just moving on to Dr. Al-Khal. You touched on long COVID, and I think it's something that people recognize now. But how do you think healthcare systems have responded or not responded to long COVID? Because frequently you see stories that it isn't something that people want to recognize. And obviously the long-term effects of COVID are being felt by people across the world. How has Qatar responded to that?
Yes, unfortunately, this major issue with COVID is underestimated, and people dismiss it as if it's not something important. It's estimated between 30 and 40% of people who get COVID will suffer from uh, persistent symptoms for weeks, sometimes months, sometimes years. For example, I have a patient who's still in a wheelchair, and he got COVID before the vaccine was available. And this also includes children. Children can have persistent symptoms because of COVID infection, including things like recurrent abdominal pain, difficulty concentration, not performing well in their studies. And there is a proof that this can be mitigated or prevented with vaccine and remaining updated on the vaccine. Also, there is evidence that it can be mitigated or prevented by administration of early treatment. And treatment is widely available now in most countries, where if it's given in the first few days, then you can minimize this risk. Unfortunately, most healthcare workers don't know how to deal with chronic COVID, so they tend to ignore it or neglect it, and patients, suffer, or patients may dismiss it as because of age, they have the symptoms, or because of other reasons. And there are not many clinical trials or basic science on, what's the mechanism, what's the pathology behind it, what treatment options there are. Most of the treatments that are available are supportive. There are some specific treatments for things like, for example, uh, drop in blood pressure when people stand up because of long COVID. There are some physiotherapy for people with fatigue that can help. There is oxygen deprivation for people with chronic mitochondrial damage that may help. So there are trials there, and I think going forward we may have more specific answers on how to prevent and how to
More
treat.
awareness of it, because many people denied that it
Awareness is
was
a
even.
major problem. I mean,
Yeah.
we keep saying you really need to get vaccinated not only to prevent acute COVID and hospitalization, but also to prevent chronic COVID.
And then there's the expectation that you should get better. And so people are frustrated when they themselves can't get better, or the people around them expect them to snap out of it. Thank you, Dr. Khal. Minister Munim, I just wondered if religion was a factor in your country in persuading people to get vaccinated. We saw in countries like Africa. Sorry, I was asking if religion or religious leaders were tools that you used to persuade people to get vaccinated, because in countries like Africa, religious or community leaders were a way to combat vaccine hesitancy. So, was it a tool that you used in your country in persuading people to get vaccinated? Yes. During COVID, when you wanted people.
Okay, thank you. I got it. Yeah, we engaged. We started a all pervasive campaign so that everybody can take the vaccine. And therefore, unlike other countries, we have enthusiastic population to take the vaccine. No wonder. That's why we could vaccine so many one day. Now
Excellent.
we engage all the apparatus, political leadership, religious leadership, religion all across, and the public faces, and put him in the national television that you can save your life, provide you take caution of yourself and take the vaccine. And it worked out pretty well. So one lesson for us, whenever such disaster happens, you see, multifarious campaigning is essential to get people involved in the process. That's that's a success story in our country.
Thank you. Great.
All classes,
Yeah, absolutely.
they got into involved.
So we have about 10 minutes left, so I'm going to open up for questions from the audience. I think there's a roving mic, so please put your hand up if you have a question. A very well-informed audience, they don't have questions. We do. Oh, there we go.
Hello, and thank you so much for your insights today. A question, if I could, Lady Roslin, on HIV in particular. We've seen a tremendous amount of progress made on HIV vaccines and other treatments in the last couple of years that in some communities seem to have come out of nowhere. Obviously, the work was going on behind the scenes, but it's been very exciting to see. Could you comment on the progress, please, and where you see that going?
We still don't have an HIV vaccine, and we've been searching for one for decades. But in fact, some of that work was the basis for the mRNA vaccine for COVID, because that that work had been done for a long time, developed in the hope of a of a HIV vaccine. But I think prospects are slightly better at the moment, given what we've seen with COVID vaccine, how very quickly it could be developed. But I mean, what that was to do with was the enormous collaboration between different countries and pharma and the amount of money put to it. There's never been any other vaccine development that's had the sort of money that was put to a COVID vaccine. And why? Because it was affecting people in all countries. So the developed world was very happy to spend money to protect its own population. But if you take TB, for example, which is basically a disease of the poor, the amount of money on R&D in TB is just a drop in the ocean. It's tiny compared with many other diseases. So we can't ignore that fact that money's put where people want to put it. But the fact that it did happen with COVID shows us that it can be done.
Thank you, Lady Ross. Does it give you a sense of encouragement or disappointment that this was done so quickly with COVID?
No, I think we all have to be encouraged by it because, as Sir Adrian said, I mean, other vaccines, years and years in the making. The malaria vaccine, we've been waiting for decades too. And there's been work all over the world on it, different kinds of vaccines. And now we actually have the prospect of a vaccine that will be mostly affordable. I say mostly, it's much cheaper than the other one that's available at the moment and approved by WHO. But, and it's really exciting, but we can't forget other tools for malaria interventions either, ones that we do know work, the prevention tools, because the vaccine will still be more expensive than some of the more traditional tools. So it will have to be carefully planned as to where you introduce the vaccine first, because there won't either be the supply or the affordability of it for the whole world that needs it, which is mostly Africa. 90% of malaria is in Africa. But where I come from, Papua New Guinea, we also have very high burden malaria. And it's still the main reason that anyone presents at a health center. It's malaria.
Wow. Surprising. Any questions? Zala?
Thank you very much for this very interesting conversation. One thing, when we talk about lessons learned, one thing that we have highlighted has been the inequality in terms of access. Now there is this new pandemic preparedness treaty that is under discussion. And one thing was that we experienced was that for sure there were not enough vaccines initially for everybody. But at the same time, there were countries like mine, Italy, who bought 3 times the amount of vaccines that they needed. And we even had to throw them away because they expired, while we saw that many African countries and low-income countries were denied even access to procurement. Do you think that this issue will be really addressed in this discussion for this new preparedness, pandemic preparedness treaty? Because I think that this is one of the key issues that really would improve the outcome globally. Thanks.
Yeah,
Please go
thank
ahead.
you. I think this is a very important question. Thanks for it. During the COVID, we faced that music because we have 170 million people. And we decided, as per WHO, that we should vaccinate 70% of our population, which means always, and these are first dose, second dose, and of course, these 2 doses. So we have to procure that. Now, at the time, the vaccines were not available, and we are not a rich country. And first is Sputnik, Russian, and then the Sinopharm from China. Well, the problem was our expert says that since they are not WHO approved, so we cannot use our population as a guinea pig, and we don't have our own vaccine. And the Pfizer, all those, they're very expensive. We can afford to buy. So anyway, finally, COVAX started giving us, and we had to spend our own money, huge amount of money, to buy. Then suddenly, Sinopharm was approved, and that was the Eureka. Immediately, we gave order, and we started buying it. But there, we had another problem. The Chinese would not deliver it. I have to send cargo to pick it up and bring it back. That's another expense. Thanks to USA, they did not do that. They delivered it. Now, when we got the little vaccine, we were prioritizing who should be using it. And that's not a good policy, because if your neighbor is sick and you are okay, in the long run, you'd be sick again. So one lesson we learned, in the case of vaccine, there should be uniform distribution of those vaccines. And our WHO, COVID, CP, they all should organize together, and thanks to Gavi, so that there is no discrimination in the distribution of the vaccines. And if we can ensure it, and future, this is a lesson for us. We should look into it so that many countries did not have vaccines, even at the last minute. It's because they neither have money or they have influence. We had to procure vaccine in varieties. We used varieties of tactics and strategies to get the vaccine from USA, for example. We have many diaspora doctors, professionals in USA, and they had to request the government, US government, that our parents are dying, our relatives are dying, and here we are providing vaccine, helping people to save, and our family are dying. So why don't you give? And only then they started giving us.
I think
So
some
it
of
was a challenge. In future, I think we should make a rule that whenever such happens, the distribution should be uniform.
Yeah, absolutely. But I think in
Thank you.
terms of, yeah, thank you, Minister. In terms of pandemic preparedness networks, one of those things we'll be looking at vaccine hesitancy and even distribution. So those topics really are foremost in the new pandemic preparedness networks that are being formulated, and interestingly in different regions. And I think one of the things that we need to kind of understand is culturally in different regions there are different problems. Now we've talked a lot about the lack of supply or oversupply in some countries, but in certain countries in Africa, vaccines were thrown away because you couldn't persuade people to take them. And the lack of infrastructure in the country didn't allow you to distribute them. The healthcare workers weren't there to do it. I think it's the first time that people talked about this a lot, that we're vaccinating the whole world at the same time. And we've never done that before. So it did present many, many problems, which we're hoping that the pandemic preparedness network will help us to solve. It won't solve all of them, but it at least will help us to recognize those problems. We have 2 minutes left, so I'm going to give everybody 30 seconds to wrap up and give me one key thing that you feel. Oh, do you have a question? A very quick question.
Thank you. First of all, congratulations, Glenn Angela, on taking on the chair's role. And on behalf of everyone from Australia, Professor Hill, thank you. Thank you very, very much. We talked about the vaccines being available globally and in greater quantities. Australia also had difficulties getting vaccines out of Europe, and they were basically being blocked. They're literally being stopped from leaving Europe under the EU rules, despite having clear contracts and all the rest of it. So if a country like Australia, with 25 million people and an established health system, and one that was actually at the same time manufacturing its own AstraZeneca vaccine, but had not yet come online, for other countries, they would be absolutely incapable of getting anywhere near having a vaccine. And so the question I have, is probably to you, Lady Rosalind, is what mechanism actually is there that could ensure broader distribution earlier on in the process? I mean,
Well, I
does
think,
that even exist?
well, I don't think it does. And that's the answer, Mr. Morrison. It doesn't exist. I mean, we relied on collaboration, which organizations did do, but it was late. It was late, and still countries faced an enormous problem. But it's a lesson for the future. I don't know how much the pandemic treaty will solve that. I'm not an expert on that, but maybe Adrian can tell us.
Can I?
I don't know the answer to that, but you said 30 seconds. Well, less time than that. Look, we're in Asia. Most vaccines every day are mainly made in Asia. During the pandemic, most vaccines were made in Asia. Not in a large number of countries, but a lot in India, in Korea, particularly in China, Indonesia, a major manufacturer. There's great strength here and capacity to build on. Asia should be supplying the world. There's the challenge.
And on
Please
that,
continue.
The Australian one,
yes,
they have around 25 million people, and they accumulated more than 80 million vaccines. So we've been asking that please share with us. Thanks God, many countries did the same. So finally, when they started sharing their vaccine, like Japan, or you see, but it was a little late. And maybe in the future we have to think that depending on the population size, how much vaccine each country should accumulate. Thank you.
absolutely. And on that happy note, I think we'll wrap up this panel. Thank you very much, panelists.